Good day. My name is Professor Olabisi Loto from the Department of Obstetrics and Gynecology, Obafemi Awolowo University, Ile-Ife. I'll be talking about assisted reproductive technology in this lecture. The objective of this lecture, at the end of this lecture, students should be able to define and identify types of assisted reproductive technology, know the indication for assisted reproductive technology, get an overview of the assisted reproductive technology procedures, including the outcome, have an understanding of surrogacy and gestational carrier, and be aware of the medical legal aspect of assisted reproductive technology. I have nothing to declare. Now, by way of introduction, infertility remains a global problem affecting about 15 to 20% of married couples. The constitutive factors are found in either the male or the female or both of them. Many of the causes of infertility are not amenable to conventional treatment. So IVF has to be the last resort for such couple. Now, infertility treatment options that involve handling the gametes and embryo in the laboratory is what is called assisted reproductive technology. And it includes intrauterine insemination, IUI, gamete intrafallopian transfer, GIFT, zygote intrafallopian transfer, ZIFT, in vitro fertilization or intracytoplasmic sperm injection and embryo transfer, IVF, ICSI. GIFT and ZIFT are hardly practiced nowadays, so what is done is the IUI, the IVF, ICSI, and embryo transfer. Now, ART refers to all techniques involving direct retrieval of the oocyte from the ovary. Looking at this definition, it will exclude IUI because oocytes are not retrieved, but most ART centers include IUI as part of the procedures. So the typical definition of ART includes procedures such as IVF, GIFT, ZIFT, and ICSI. The simplest ART procedure is IVF, and it has been around for over 40 years. In fact, the first baby that was born through IVF was born over 40 years ago in the name of Louis Brown in 1978. What are the indications for ART? Women with tubal diseases such as women with blocked tubes, people with unexplained infertility, people with severe endometriosis, immunological causes of infertility, women with premature ovarian failure, individuals with male factor infertility, and so on. These are people that will benefit from assisted reproductive technology. Now, a brief comment on IUI, intrauterine insemination. The aim of intrauterine insemination is to deposit prepared semen into the uterine cavity around the time of ovulation with the aim of causing fertilization of the released oocyte and implantation of the embryo in the uterine endometrium. It can be done with husband's sperm or with donated sperm if the man has azoospermia. Treatment of infertility in selected couple has been achieved with IUI. So this picture, shows the IUI procedure. You can see the sperm is deposited close to the fundus of the uterus, and they travel down the fallopian tube to get the ovum that has been released. Now, this will tell us that a woman with bilaterally blocked tube cannot benefit from IUI. It will be a waste of time because expect the ovulated egg to travel through the fallopian tube, and expect the sperm to pass through a patent fallopian tube to be able to meet up with the egg. So IUI is for people that have at least one patent tube. It cannot be a treatment for somebody with bilateral tubal blockage. So indications for IUI include unexplained infertility, mild to moderate oligospermia, because in the process of preparing the sperm, we concentrate the sperm together so that we have enough total motile sperm to deposit in the uterus at the time of ovulation. Then you can also use IUI in azoospermic, people that don't have sperm in their ejaculate. But in this case, you have to use donor sperm. Then when you have tried ovulation induction in people that have unexplained infertility and you are not successful, you can move on to intrauterine insemination. Then following tubal repair, post-tuboplasty, one can try IUI. But like I said before, you need at least one patent fallopian tube to qualify for IUI. Patient selection is very important. and ovarian reserve assessment is also important in people going for IUI. And the reason is that you want to be sure that there's no contraindication to IUI, like blocked tubes or premature ovarian failure and all that, which will warrant other forms of treatment rather than IUI. Then you induce ovulation with clomiphene or tamoxifen or with gonadotropin, like we have talked in the other lecture on ovulation induction. Then you monitor follicular growth with transvaginal scanning. Then you trigger ovulation with HCG when the dominant follicle is greater than 80 millimeter in diameter based on the ultrasound scanning. Then the sperm is collected, washed and prepared, and the woman is inseminated 40 hours after the HCG injection. The HCG injection serves as the LH surge, so you expect 36 hours later for the woman to ovulate. So, and the IUI is done after the 36 hours, maybe from 38 hours to 40 hours to give time for the egg to be traveling along the fallopian tube. Then most people will give luteal support with progesterone following IUI, and pregnancy test is done 2 weeks after IUI. Success rate is about 8 to 18% for IUI. And the reason for the low success rate is because the woman and the husband may have an inherent problem why they are not getting pregnant in the first instance. So IUI will not just overcome everything. The aim of IUI is to bring the egg and the sperm close together to see what will happen. Now, the next one is in vitro fertilization and intrasatisfying sperm injection, ICSI. In vitro fertilization involves the fertilization of the oocyte outside the body environment. That is why it is called in vitro, in the petri dish in the laboratory, and the transfer of the resulting embryo into the uterine cavity 2 to 5 days post-fertilization. It is called test tube baby. I don't know why, but the baby is not cultured in test tube, but the baby is cultured in a petri dish. So maybe petri dish baby instead of test tube baby would be a more appropriate description. But usually, simple insemination is done when the sperm parameters are normal. And in simple insemination, that is the conventional IVF, the sperm is added to the egg in the petri dish and incubated overnight. And then they are examined for evidence of fertilization by checking for pronuclear inside the oocyte. But when the sperm parameter is very poor, you cannot guarantee fertilization. That is when ICSI comes into play. ICSI is the art of injecting one sperm into each egg to ensure that the sperm gets inside the egg. For people that have very low sperm count, you have to inject the egg one at a time with a sperm, which is picked up by the embryologist under the microscope, using what is called the micromanipulator. So, for people that have poor sperm parameter, IVF is what is done. Anyway, ICSI is what is done. For people that have normal sperm parameter, IVF is what is done. So, indication for IVF, when a woman has bilaterally blocked tube. We talked about IUI before, that if the tubes are blocked, you cannot do IUI because the egg will not have a space to pass. So those people should be put for IVF straight. Because for IVF, you don't need the tube. Fertilization takes place outside the body, so in the petri dish, so the tube is of no use there. So people that have blocked tubes should go for IVF or ICSI. People that have severe oligospermia or obstructive oligospermia should go for ICSI. In ICSI, the advantage of ICSI is that you don't need normal number of sperm. Once you can get a few number of sperm, it can be injected into each egg. Even if you get 8 eggs, all you need is 8 sperm for the 8 eggs. And then you are already ongoing in your treatment. So if you have obstructive azoospermia, you can actually extract sperm from the testes using surgical sperm collection technique like testicular sperm aspiration, TESA, or testicular sperm extraction, or epididymal sperm extraction. You can get those sperm and use it to do your ICSI. So, and the man will be able to have his own biological child. The alternative is that the man may go for IUI with a donated sperm, which may not be culturally acceptable to some people. Then when you have failed conventional treatment of infertility, you can move on to IVF ICSI. When IUI fails, you have to move up the ladder to IVF. In postmenopausal women, IVF is the only option because they are no longer producing eggs, so you need to use egg donation and then IUI to be able to get pregnant. Now, for IVF ICSI, selection of patients is very important. You have to carry out your ovarian reserve assessment, evaluate the uterus to be sure that the cavity is okay because you are going to transfer and do all the necessary tests. Also evaluate the man. Proper counseling is important because IVF is not 100%. Some people come to IVF thinking that it's going to be 100%. It is not. So they have to be properly counseled. That the chance of getting pregnant, is inversely proportional to the age of the patient. A woman over 40 may have just about 5% chance of getting pregnant, with IVF using her own egg, while somebody under 30 has over 40% chance of getting pregnant. So after proper counseling and sounding the necessary consent, control ovarian hyperstimulation is proceeded on with gonadotrophin, depending on the protocol that you are using, either the long protocol, the short protocol, or the antagonist protocol. Some people have talked about the use of clomiphene to start the stimulation process in the so-called low-cost IVF in order to bring down the total cost of the IVF. Then, monitoring is essential in the IVF process. You have to monitor to prevent the side effects such as ovarian hyperstimulation syndrome. So, and how do you monitor? You have to use the estradiol level because if you go, like I said, under the ovulation induction, a rapidly rising estradiol will tell you that this woman will end up with ovarian hyperstimulation. So you have to be careful. Then ultrasound is used to monitor so that you know the time to give your HCG trigger. Then egg retrieval is done under ultrasound guidance 34 to 35 hours after the HCG injection. Why that one is done, why that timing is important, because if you wait till after 36 hours, ovulation may have occurred and you find out that you won't be able to get any egg. Why in IUI you wait for ovulation to occur because that's what you want so that the sperm will meet an egg. In IVF, you have to get the egg retrieved before ovulation occur. So that's why you have to do the timing to be around 34 to 35 hours after the HCG injection. Then you do IVF, conventional IVF, or ICSI, depending on the sperm parameter of the man. And then you do embryo transfer back into the uterus, maybe 2 to 5 days post-insemination. Then you support with luteal phase progesterone in order to enhance further growth of the baby in utero. And why do people do luteal support? It is believed that you need to give progesterone because the process of aspirating the egg may have removed some of the corpus luteum cells, and so the progesterone production may be suboptimal. So you have to support with progesterone while waiting for the pregnancy to take hold. Other people have given several reasons why they need to do luteal support, but that is the major reason why luteal support is done. Success rate for IVF is between 25 to 35%. We are talking of take-home baby rate now. So things that affect the outcome of IVF include the sperm quality. Now, the sperm quality will impact the quality of the embryo that you eventually get. If the sperm quality is poor, the embryo quality will be poor, and the implantation potential will also be poor. But the sperm quality is good, the embryo quality may be good, and the implantation potential may be good. Now, apart from sperm quality, the age of the woman is also there because it's also the age of the woman is the single most important factor that determines the quality of the oocyte. Because as a woman gets older, the quality of the oocyte declines. Then other uterine factors such as Asherman syndrome that may affect implantation may also need to be looked into. So that when a woman comes for evaluation for infertility, thinking of doing IVF, you need to look at all those factors and be able to prognosticate their chances of getting pregnant with that procedure, considering the fact that IVF is very expensive. So they should know what are the chances, and then all this should be thoroughly discussed. Endometriosis also affects the quality of oocyte. Then the drug and stimulation regimen use may also be a factor. Embryo quality, which we have talked about, is the outcome of the sperm quality and the age of the woman. Then the laboratory environment. You need to keep the laboratory environment very clean and free from all the volatile organic compounds that may affect the quality of the embryo. Complications of IVF include bleeding and pain at egg retrieval, infection, ovarian hyperstimulation syndrome, which we have talked about before, and we have talked about the risk, which include PCOS, young patients, people with low BMI, and it can be mild, moderate, or severe, as the case may be. Now, a brief mention about third-party ART. Third-party ART includes the use of sperm donation, egg donation, surrogacy, etc., where you are including a third party apart from the husband and wife. Where the husband does not have sperm and you need to use sperm donation, that's also a third party reproduction. Where the woman is not able to carry the baby because of disease of the womb or cancer, or where the womb has been removed from previous surgery, you need to use a surrogate to help her carry the pregnancy. That is third party reproduction. Now, you need to make a decision between surrogacy and gestational carrier. People use it interchangeably, but the distinction is basically scientific. A surrogate is somebody who helps a woman to carry a pregnancy, and the egg that they use to achieve that pregnancy is coming from the surrogate, from the woman that is carrying the pregnancy. That is called surrogacy. In gestational carrier, the baby is not genetically related to the woman that is carrying the baby. The egg may come from the wife, the sperm from the husband. All she does is help them to carry the baby for 9 months and give back to them. So that is a gestational carrier. So she is not related to the baby in any way. But for traditional surrogacy, the woman that is carrying the baby is the one that donated the egg. So I think that distinction is important for when you are talking to couples who are interested in doing those things. So what are the indications for gamete donation? Azoospermia. Azoospermia, where the man, in his semen, there's no sperm at all that can fertilize an egg. So you need to use sperm donation. In case of genetic or inheritable diseases that may not be compatible with life or that may have debilitating effects, you can use gamete donation in order to circumvent that. Advanced maternal age with repeated own egg failure, you can also use gamete donation. For example, a woman that is postmenopausal that wants to go through IVF, of course, she has no egg. You have to use gamete donation in that woman. The woman that is over 42 who wants to go through IVF and you have done the ovarian reserve testing and it's very low, you can advise on gamete donation because you know that our chance of getting pregnant with our own egg is less than 5%. And also there's a risk of Down syndrome, chromosomal abnormality in the offspring based on the age of the mother. So those are the things you consider before you offer them gamete donation. So indication for surrogacy and gestational carrier, badly damaged uterus like in Asherman syndrome. You know, there are some Asherman syndrome that go through repeated treatment and yet you are not having any leeway. Such people will benefit from gestational carrier. Post-hysterectomy, that is removal of the womb for whatever reason, such women may benefit from gestational carrier. Congenital absence of the uterus, serious maternal illness that contraindicate pregnancy. Like, for example, somebody that has heart disease, New York Heart Association Class 4, who is already tired at rest, cannot carry a pregnancy. So such people will need a gestational carrier. Now, a brief mention about ethical or legal issues of IVF. IVF is new. It's a new method of reproduction. And so it has generated a lot of ethical and legal issues. So, especially from religious bodies and even moral theologians, the entire approach to pregnancy, people have asked, is it morally or culturally or religiously right to do so? Are you separating the act of pregnancy from the act of coitus? So the debate is ongoing. Then, do you discriminate against a woman on account of age? What is the oldest age in which you can allow a woman to go through IVF? So those are issues that need to be answered, and they don't have right or wrong answer. Then pre-implantation genetic diagnosis. For example, somebody that has that is AS, marrying an AS, you can do IVF and then select only the AA or AS baby for implantation and discard the SS, SS embryos. Now, is it right to discard the SS embryo? I didn't know human being. People have talked about it. That means you are throwing away a person just because it's SS. Gamete donation. Will you tell the child, after the child has grown up, that it was somebody that donated the egg or the sperm? So all these are ethical issues that need to be, that are ongoing. Discussions are ongoing about how to resolve this. Now, surrogacy needs proper documentation, especially the traditional surrogacy, in which the woman will donate the egg and carry the baby, because the woman can claim to be the owner of the baby. And so, you need a proper documentation. Some lawyers have opined that after surrogacy, the couple should formally adopt the baby from the surrogate mother. I don't know, Nigeria doesn't have a law yet on this, but that is part of the problem that people can go. So, all these ethical and legal issues are there in IVF, and the list is endless. And every time you see people throwing up new cases. For example, in some countries, gamete donation, egg donation is not allowed. And people have gone to other countries to go and have their IVF. But the problem is, there's a case of somebody going to India to have a baby. Meanwhile, in Germany, egg donation is not allowed. So they didn't give the baby the German citizenship. So, and that became a problem. And then the Indian people said the baby is not from there because it's from Germany. So eventually they had to find a way of getting their baby across to Germany by getting visa from for the child from German embassy. So those are part of the issues that occur with the IVF, especially with cross-border reproduction. IVF has allowed for cross-border reproduction. People go to another country to go and do what is not legal in their own country or what is not ethical. And so the challenges are myriad. So, and everything has to be taken into consideration when going or counseling couple for that issue. So in conclusion, ART is a last resort for some couple. Equity in healthcare services for every citizen imply that people should be able to allow to have children. Because in Nigeria, there's no money is not being voted for IVF because we believe that we are overpopulated. Now the question is, people that don't have children, don't they have a right to have their own child? Are we only interested in family planning? People say it's too expensive. Government can always, when there is malaria, there's TB to fight. But these people also pay tax. So why can government not take care of them by setting up centers in which they also will be able to be taken care of? But of course, that is another debate. We have limited resources, so we cannot afford to invest in very high amount of, very high cost, IVF treatment centers. And so those people are left out. There's also the need for research in the area of low-cost IVF so that more people will be able to get it in Nigeria at least. There's need to make sure that ART is safer by proper training of the practitioner. There's also the need for proper selection and preparation of patients for optimal outcome of ART. Thank you for listening.